Hello everyone, welcome to your 3-question warm-up. Let's get going. A woman presents with headache, visual disturbance, and amenorrhea. What is the diagnosis? The answer is probably a pituitary adenoma. Next question. A patient presents with hypertension, hypokalemia, metabolic alkalosis, and low plasma renin. What is the diagnosis and how do you treat it? So this is primary hyperaldosteronism, or Conn syndrome, and you would treat this with spironolactone. Too much aldosterone, so you're going to use an aldosterone antagonist. Next question. How does the brain utilize ketone bodies? Well, the brain is going to metabolize ketone bodies into 2-acetyl-CoA molecules, which are then used in the TCA cycle. All right, that brings us to the end of the warm-up. Let's get to that lecture.
We've already covered individual types of cancer separately. So we covered breast cancer in the reproduction section, we covered colon cancer and GI, we covered lung cancer and pulmonary. We're not going to go over all that again. But in these oncology videos, I'm going to focus on some of the big overview topics like the genetics of cancer, cancer risk factors, cancer screening guidelines. And then we'll finish by discussing cancer drugs, which are particularly high yield. Now in this first video, I'm going to review a lot of cancer terminology and nomenclatures, which can get a little confusing. Let's start with the difference between hyperplasia, dysplasia, and neoplasia. So when a tissue develops hyperplasia, that means there's an increased number of cells. Normal cells, just too many of them. Then metaplasia is where one normal cell type is replaced by another normal cell type. So Barrett's esophagus is an example of metaplasia, where the normal squamous epithelium is replaced by columnar cells that resemble intestinal epithelium. That's metaplasia. And then dysplasia means abnormal growth, with loss of normal size and shape and orientation. And all these three so far are reversible. Hyperplasia, metaplasia, and dysplasia are all reversible. The next step is anaplasia, which is irreversible. So anaplasia means that the cells are regressing, becoming less differentiated, less like mature cells and more like primitive cells. And there are some distinct features of anaplastic cells that are probably worth writing down. There's a high nucleus to cytoplasmic ratio, so very little cytoplasm, lots of nucleus, prominent nucleoli, clumping of the nuclear chromatin, and these cells have many mitotic figures. So if you're looking under a microscope and you see any of those 4 findings, you might be dealing with an anaplastic cell. Then neoplasia means new growth. So here the cells are growing in an uncontrolled fashion. But neoplasia, neoplasm, could be either benign or malignant. The term neoplasm doesn't necessarily mean malignancy or cancer. It's like the word tumor. Not all tumors are malignant. Next, let's talk about the nomenclature that tells you what cell type a tumor arose from, or what cell type it resembles. Now, this is a topic that students tend to breeze through thinking they already know this, but it's important to know. So a benign tumor arising from the epithelium is either going to be an adenoma or a papilloma. Adeno means gland. So adenomas have glandular architecture, even if they don't arise from glandular organs. Remember, for example, that the most common type of colon polyp is an adenoma, an adenomatous polyp. Then papilla means nipple. So papillomas don't originate from the nipples. That means that their microscopic architecture has little finger-like or nipple-like projections in a papilloma. Now, a malignant tumor arising from the epithelium is called a carcinoma, either adenocarcinoma or papillary carcinoma. Now remember, back in foundations, what kind of stain do we say we used for carcinoma? Cytokeratin. Remember, cytokeratin stains for epithelial tissue. It's also worth knowing that most epithelial tumors tend to spread mainly by lymphatics, while mesenchymal tumors tend to spread hematogenously. There are some exceptions, but that's a pretty good rule of thumb. So, what are some types of mesenchymal tumors? Well, blood cell tumors, including leukemia and lymphoma and multiple myeloma. Blood vessels give rise to benign hemangiomas, like a cherry hemangioma is a benign growth on the skin. And then an angiosarcoma is a malignant blood vessel tumor. And angiosarcoma most commonly occurs in the liver. Sometimes it's called a hemangiosarcoma. It's the same thing. Now, most of these mesenchymal malignancies are going to be some type of sarcoma. Generally, sarcomas are less common than carcinomas, but they tend to be more aggressive. So a benign bone tumor is an osteoma, and a malignant bone tumor is an osteosarcoma. Fat tumors are either lipomas when they're benign or liposarcomas. And for most of these mesenchymal tumors, it's actually pretty rare for the benign tumor to progress to the malignant tumor. So lipomas are very common, but they almost never become liposarcomas. Now that's not the case with epithelial tumors. Adenomas can become adenocarcinomas, like colon cancer. Skeletal muscle tumors are called rhabdomyomas when they're benign, and then rhabdomyosarcomas when they're malignant. Smooth muscle tumors are called leiomyomas when they're benign, and then leiomyosarcomas when they're malignant. And then one more term I'm going to throw in here, somewhat related to this, is a teratoma, which is a tumor with more than one cell type. So a mature teratoma is made up of mature tissues, no anaplastic cells. We most often see mature teratomas as ovarian tumors, and they can grow teeth and hair and thyroid tissue, all sorts of things. Then the malignant counterpart to that is called an immature teratoma. Next, let's talk about the concept of tumor grading and staging. Grade is a description of how much cellular differentiation and mitotic activity the tumor cells show microscopically. So grading is done by the pathologist, looking at the tissue sample under the microscope. Low grade means there's more differentiation because the cells still resemble more or less normal cells. But high grade means there's less differentiation as those cells become less normal. Then tumor staging is based on how big the tumor is and how much it's begun to spread. This is where we use the T&M staging systems. The T in T&M is for tumor size, the N is for nodal involvement, and then the M is for metastasis. Now, for purposes of prognosis and determining treatment, it's usually the stage of the cancer that's more important. We tend to make clinical decisions about whether or not to use chemotherapy or radiation or surgery based on how much tumor you're dealing with and whether or not the cancer has begun to spread to the lymph nodes or distant tissues. And again, that's a question of staging, not grading. So, how does a benign tumor become malignant and start to spread? Well, there are several steps involved. First, there might be progression from normal to hyperplasia, where you just have increased cell number. And then as those cells begin to lose their normal size and shape and orientation, we call that dysplasia. And remember, normal tissue is generally very organized and orderly, but with dysplasia, things are starting to look disorganized. And then that dysplastic tissue can become carcinoma in situ. So with carcinoma in situ, you have malignant cells, but they haven't yet invaded the basement membrane. Then when the tumor cells break through the basement membrane, we say they're locally invasive. And if they invade a lymphatic or a blood vessel and then they travel to other parts of the body, we say they're metastatic. Now let's talk about which cancers metastasize to which organs. We've got some pretty good mnemonics for these. Start with the liver. Our mnemonic for the common cancers that cause liver mets is cancer sometimes penetrates benign liver. I love it when mnemonics relate to what you're trying to remember. Cancer sometimes penetrates benign liver. So the C is for colon, the S is for stomach, P is for pancreas, B is for breast, and L is for lung. Now we're going to see breast and lung cancer metastasizing to all these different sites because they're very common tumors. They tend to turn up in lots of other places. But think about the organs that drain to the liver. The colon drains to the liver, the stomach drains to the liver, and the pancreas is right there next to the liver. So cancer sometimes penetrates benign liver. Then what kinds of clinical manifestations would you potentially see with liver mets? Well, you might see elevated LFTs, especially alkaline phosphatase. You can see liver tenderness or abdominal pain. You could have some hepatomegaly, enlargement of the liver, or there might be some signs of hepatic dysfunction like ascites or jaundice. And very briefly, when a cancer starts in the colon and then metastasizes to the liver, do we say that patient has liver cancer? No, the patient has colon cancer metastatic to the liver. Now you probably understand that, but be aware that many non-medical people don't understand that. So when a patient tells you that his mother died of liver cancer, you have to dig a little deeper. In fact, in most cases when someone turns up with a liver tumor, your first thought should be metastatic disease because that's much more common than primary hepatocellular carcinoma. Next up, let's talk about mets to the brain. About 50% of brain tumors are from metastatic disease. So if you're asked what's the most common type of brain tumor, the answer is mets. Now, the mnemonic for brain mets is lots of bad stuff kills glia. So the L is for lung cancer. The B in bad is for breast cancer. Remember, we see lung and breast in all these. Then the S in stuff is for skin, which is melanoma. The K is for kidney or renal cell carcinoma. And the G is GI tract, especially colon cancer can go to the brain. Then what kinds of clinical manifestations do brain mets cause? Well, headache would be a big one. About 50% of patients with brain mets have headache. Now, most headaches are not caused by brain tumors, but tumors can definitely cause a headache. Focal neurological deficits are common, like hemiparesis, and so is cognitive dysfunction, like memory loss or personality changes. Then you can also see seizures. And then what kinds of tumors metastasize to bone? We talked about this in rheumatology, but our mnemonic was permanently relocated tumors like bones. Prostate, renal cell cancer, the T in tumors is thyroid, and then like bones is lung and breast. Again, you see lung and breast in all these lists. Remember, there's a genitourinary association with bone mets. Prostate can go to the bone, renal cell carcinoma can go to the bone. And then don't forget that some bone mets are lytic, meaning they're breaking down the bone locally, like lung cancer does. Some bone mets are blastic, which means they're building new bone, but it's not healthy, strong bone, it's disordered, weak bone, and it fractures fairly easily. Remember, prostate cancer mets are blastic lesions. And then breast cancer mets to the bone can be either lytic or blastic. Now, one very high-yield topic regarding cancer is paraneoplastic syndromes. Paraneoplastic syndrome is some clinical effect that the cancer is causing that's not due to the local effect of the cancer cells. So if you have bone mets in the spine and that causes compression of the spinal cord and causes a loss of bowel control, that's not a paraneoplastic syndrome. That's due to the local effect of the tumor itself. When we talk about paraneoplastic effects, we're usually meaning that the tumor is producing some type of hormone that causes systemic effects. Now, these paraneoplastic syndromes are probably a 3 or 4-star topic, so make sure you know these. Now, lung cancers are especially famous for causing paraneoplastic effects, especially small cell lung cancer. Small cell lung cancer can sometimes secrete ACTH, or adrenocorticotropic hormone, and that's going to increase cortisol and cause Cushing syndrome. Small cell cancer can also release ADH, or antidiuretic hormone, and that can cause SIADH, the syndrome of inappropriate ADH secretion. And that leads to decreased serum osmolality and hyponatremia, potentially seizures with that. Now, besides small cell lung cancer, it's often said that anything in the brain can cause SIADH. So intracranial neoplasms can also cause SIADH. Then a third paraneoplastic effect from small cell lung cancer is Lambert-Eaton syndrome. Sometimes it's called the Lambert-Eaton myasthenic syndrome because it looks a lot like myasthenia gravis clinically. It's a syndrome of muscle weakness, and it's caused by antibodies against presynaptic calcium channels at the neuromuscular junction. So the tumor induces the immune system to produce antibodies that attack these calcium channels on the presynaptic nerve terminals so that they can't release neurotransmitter, and therefore you don't generate a muscle contraction. So you test for this by doing an isometric muscle contraction. To do an isometric muscle contraction, you have the patient flex the arm against some resistance. And with Lambert-Eaton syndrome, that isometric contraction is going to let some calcium kind of build up. And then when you let go and you let the patient contract on their own, the patient's stronger than they were before. They're able to contract more strongly than they were before. So, or sometimes you do that isometric contraction and the reflexes improve. So this is a weakness that improves with use. Now that makes it distinct from myasthenia gravis, which is a weakness that gets worse with use. Now, besides small cell lung cancer, squamous cell lung cancer can also cause a paraneoplastic syndrome of its own, and this is hypercalcemia. Specifically, it's called the humoral hypercalcemia of malignancy. So this is where the squamous cell lung cancer secretes a protein called PTH-related peptide, or PTHrP. This PTHrP behaves a lot like parathyroid hormone. So it causes increased bone turnover and increased calcium reabsorption in the kidney, and it raises serum calcium. And besides squamous cell lung cancer, other squamous cell tumors can secrete this PTHrP. So think about things like squamous cell cancers of the head and neck, and then also breast cancer and renal cell carcinoma. Now, there was another cancer that commonly causes hypercalcemia along with symptoms of back pain and anemia and renal failure. You remember what that was? Multiple myeloma. But I mentioned that multiple myeloma causes hypercalcemia through a completely different mechanism. Remember what that mechanism was? I can't hear you. Myeloma secretes local osteolytic factors that lead to lytic bone lesions and hypercalcemia. And that's not considered a paraneoplastic syndrome. But remember, there's more than one way that cancer can cause hypercalcemia. For example, some lymphomas, especially Hodgkin lymphoma, will secrete the active form of vitamin D, and that leads to hypercalcemia. And then finally, we've mentioned that there are 4 main cancers that can secrete erythropoietin, and that can lead to paraneoplastic polycythemia, increased red blood cell mass. And our mnemonic for these was potentially really high hematocrit. Again, it goes along with what we're trying to remember. So the P in potentially is for pheochromocytoma, then you have renal cell carcinoma, hepatocellular carcinoma, and hemangioblastoma. And I didn't mention this one before, but rarely uterine fibroids or leiomyomas can also secrete a little bit of erythropoietin, which is really interesting because often these fibroids will cause hemorrhage and anemia. So if on your exam they give you a patient with fibroids and heavy bleeding, but she's not anemic, it may be that the fibroids are making erythropoietin. Now, there are two more cancer-related terms I want to go over very briefly before we get to the end of session quiz. The first one is cachexia. Cachexia is where patients have profound weight loss and loss of both fat and lean muscle. Now, it's not just a matter of the cancer cells using up all the patient's nutrients. What's really happening is that the tumor is producing cytokines like TNF-alpha, and those cytokines raise the patient's basal metabolic rate. But cachexia is important because it's one of the major causes of cancer death and disability. Then the last term I want to mention, because it really doesn't fit anywhere else, is psammoma bodies. Now, psammoma bodies are a histological finding that can be seen in several different cancers: papillary thyroid cancer, serous papillary cystadenoma of the ovary, meningioma, and malignant mesothelioma. Now, psammoma bodies are laminated concentric calcific spherules. That's a mouthful. What does that mean, laminated concentric calcific spherules? It means that you have concentric rings of calcium that are laid down in sheets so that it looks like rings on a tree. So this is a biopsy of a papillary thyroid cancer. So be able to recognize that as a psammoma body, and remember those four cancers where we find them: papillary thyroid cancer, serous papillary cystadenocarcinoma of the ovary, meningioma, and malignant mesothelioma. All right, let's go ahead and do the end of session quiz. All right, first question. What type of tumor matches each of the following? Benign tumor of the epithelium is either going to be an adenoma or a papilloma. Malignant tumor of blood vessels is an angiosarcoma, or we said sometimes it's called a hemangiosarcoma. Benign tumor of the bone is an osteoma. And malignant tumor of the smooth muscle is a leiomyosarcoma. Next, what's the most common cause of hypercalcemia? So we talked about malignancies that cause hypercalcemia, but the most common cause of hypercalcemia overall is primary hyperparathyroidism. Now, malignancy is number 2 overall. So the top 2 causes of hypercalcemia are going to be primary hyperparathyroidism and malignancy. Then the next part of the question asks, what cancers may cause hypercalcemia? Well, there's squamous cell lung cancer, that's a big one. We also mentioned squamous cell cancers of the head and neck, breast cancer, renal cell carcinoma, multiple myeloma, Hodgkin lymphoma, and some types of non-Hodgkin lymphoma. And then also, don't forget, lytic bone metastasis. Lots of different ways that cancer can cause hypercalcemia. Next, what neoplasm is most commonly responsible for each of the following paraneoplastic syndromes? So, secretion of ACTH leading to Cushing syndrome is typically small cell lung cancer. Secretion of erythropoietin causing polycythemia. Remember, the 4 main cancers you need to know are pheochromocytoma, renal cell carcinoma, hepatocellular carcinoma, and hemangioblastoma. And then secretion of ADH leading to SIADH is going to be small cell lung cancer classically. And remember, pretty much any type of intracranial tumor can do that as well. Remember, anything in the lung and anything in the head can cause SIADH. And the last question, which cancers metastasize to the bone, to the brain, and to the liver? So for bone mets, the mnemonic was permanently relocated tumors like bones. So that's prostate, renal cell cancer, thyroid, lung, and breast. For brain mets, the mnemonic is lots of bad stuff kills glia. Lung, breast, the S is for skin or melanoma, K is kidney or renal cell carcinoma, and then the G is GI tract tumors such as colon cancer. And then for liver mets, we have the mnemonic cancer sometimes penetrates benign liver. Colon, stomach, pancreas, breast, and lung. All right, that's it for the end of session quiz. I'll see you next time.